everyone, and welcome to Your Health, Your Choice. I am Dr. Roopnarine, and we are coming to you live from our studios here at ACTN. On tonight's program, we're going to be talking about diabetes. In studio with me tonight is Dr. Navindra Persad. Dr. Persad is a consultant endocrinologist. Dr. Persad is the medical head at the Point Fortin Hospital. Dr. Persad also has offices at the Gulfview Medical Center in Laramie. As usual tonight, our numbers should come up at the bottom of your screens, and we'll do our very best to answer each and every one of your questions during the program. So guys, let's get the show going. Let's talk about diabetes, and let's say hello to Dr. Navindra Persad. Doc,
Hi.
Welcome to the program.
Hi. Thank you.
It's a pleasure to have you. It's the first time we're meeting.
Yeah.
I know you're doing wonderful things down there in Point Fortin. You're the head of medicine in Point Fortin. You're also in charge of the adolescent clinic in San Fernando General Hospital. And I know you have a busy private practice in Gulfview as well. So diabetes is a topic that we haven't really touched on. We were in recent times on this program. Our former host used to discuss diabetes a lot, and our audience is very much in tune with diabetes. It seems to be like the national pastime of Trinidad and Tobago talking about diabetes. However, after several months, we're now coming back to the topic, and I'm very keen for our audience to hear your unique perspectives on the topic and on the field of diabetes as well. So I'm really honored to have you on the program tonight, Navindra. First thing first, Navindra, just tell our audience about the impact of diabetes on Trinidad and Tobago, because sometimes we could be information overload, and then people get very fed up of hearing about the same things over and over. But it is a real significant problem in Trinidad and Tobago. We've coming out of the pandemic, and we need to really focus now on an issue like diabetes. So can you just describe to us or tell our audience what is the prevalence of diabetes worldwide, and what is the impact of diabetes in Trinidad and Tobago, and why it is important that you discuss that topic tonight?
Sure. So I'd like to get to the first slide.
Yeah.
And here we just show the global prevalence of diabetes.
Yeah.
There you could see from 2007 to what is expected in 2026, we're looking at a global increase of 55%. In the Latin American and the Caribbean,
Yeah.
look, we're looking at a doubling in the number of diabetes.
Right.
So it's really a big problem. You can also look at Africa, 80%. 80% again in the Middle East increase. We're looking at the Americas is 40%, but Latin America and the Caribbean is by far one of the worst hit region in the world in terms of diabetes in the world. Now, we don't have much data on Trinidad itself.
Right.
So if you look through, PAHO has data going back from 2007, straight to the last data would have been 2011, and we've been hovering between 10% to 13.5%.
Right.
We haven't done any data recently.
Right.
However, despite our actual figures confirmed
Yeah.
being about 13% of patients, we estimate that there are at least that number of patients existing.
Right.
So we are talking about 145,000 people in Trinidad confirmed with diabetes, and we estimate that there are as over 100,000 persons in Trinidad who have diabetes and are unaware.
Okay. So that's a significant amount. You're talking about nearly 200,000 people who will be impacted directly by diabetes in this country, in a population of 1.4 million people.
Yes.
That's the estimated projections at the moment. That's the estimate on the ground at the moment. Is that figure likely to rise or go down?
That figure will only get a lot worse. So type 2 diabetes is based on insulin resistance.
Yeah.
One of the main reasons for insulin resistance is obesity,
Yeah.
central obesity.
Yeah.
And we've been hearing it over the years, for the last 5-6 years, repeatedly. The children in Trinidad, we have a big problem with diabetes. Based on which figures are here, we are either number 1 to as low as number 5 in the world for childhood obesity.
Right.
I run the adolescent clinic.
Yes.
And in that clinic,
Tell us a little bit about that, Doc. I mean, when we were talking earlier before the program, we were sending messages, talking to each other, and one of the reasons why I had you on the program and discussing diabetes, because I felt that you are now the senior doctor in the hospital. You're in charge of the adolescent clinic, and I just felt that you were seeing things and that you needed to express you needed a platform to deliver a message to the people, right? What is it that you're seeing in the adolescent clinic that has you a little bit uneasy? Right. What is it that you need to tell our public about that you are seeing?
So if we look back at 10 years ago, 90% of children, meaning those under 18 with diabetes, were type 1.
Yes.
Now we are seeing worldwide, and this is not just Trinidad, we are seeing 50-50.
Right. If you could just tell the audience what is type 1, that's briefly so they'll understand.
Type 1 diabetes is where you have autoimmune destruction of the pancreatic cells that produce insulin. So your body can't produce insulin. So type 1 diabetes, you just cannot produce the insulin. Type 2 diabetes is insulin resistance, which is causing your sugar to rise.
Right, so type 1 is usually the kids that were born with diabetes?
So that's the one that we are accustomed saying juvenile diabetes or diabetes, childhood diabetes.
Right, so what you are saying to us now is that as practitioners, as public, we'd expect the kids in the clinic to be type 1 who are diabetic because they're kids, they probably had a genetic problem, they're born with diabetes. But what you are saying is that is no longer the case, that you're seeing 50-50.
Yes.
So we're seeing 50% of the kids coming in with type 2 diabetes. And type 2 diabetes, am I right by saying that is a lifestyle condition a lot of the times?
So not exactly. So it is by and large genetic.
Yes.
So if you're going to become diabetic because of your genetic predisposition, you are going to have diabetes. The question is, are you going to develop diabetes at the age of 70 or at the age of 12?
I understand your point.
So if you have the wrong lifestyle, you're going to put additional stress on the body, and you're going to end up with diabetes at an earlier age. So with the children, we're talking about the childhood obesity and all these sugary foods, Starbucks especially, all these children just, that's their food. They don't eat food, they don't eat fruits.
They drink the chillers.
Yes, and those are loaded with high amounts of sugar that they have. One of those Starbucks chillers has 2 days worth of sugar.
We wouldn't really name the company going forward.
Okay.
These chillers and there's have a lot of sugar.
So it's basically all those chillers.
All right. So what you're saying is that you're seeing in the adolescent clinic, you're seeing a huge amount of kids with diabetes. Is that the most common presentation of illness in the adolescent clinic?
Yes. So in the clinic that I have, so I see up to the age of 18 in that clinic. And once as they around puberty, I would see them. And it's 90% of the patients in the clinic have diabetes.
Right. So I remember another diabetologist was telling me that genetics is like the loaded gun. And how we live is whether we pull the trigger or not.
Yes.
Is that true?
Yeah, that's a good way to describe it.
Right. So what you are saying is that, I mean, trying to break it down for our audience to understand, is that we pull in the trigger too early.
Yes.
And kids are developing full-blown symptoms because of lifestyle. We pull in the trigger too early. Whereas if they modify the lifestyle, the trigger will be pulled because of genetics, but it will be pulled later on.
Later on.
All right. So is that a recent phenomenon worldwide where we see an earlier age of presentation of type 2 diabetes?
Yes. So worldwide, so in the last 5 to 10 years, the incidence of type 2 diabetes in the 12 to 17 age group has increased by about 200%.
Wow.
The incidence of type 2 diabetes in the under 26 age group has doubled.
Right.
And we estimate that the numbers are far more because teenagers and people in their 20s are healthy, and when you're young, you're not going to feel the impact. So when a 20-year-old has a diabetes, most of the time we don't know until their sugar tends to be usually 400, their HbA1c. Most of them in the 20s would have a HbA1c when they first present over 10%.
Okay.
Whereas when we see those over 55,
Yeah.
they usually present with a A1C 7.5 to 8.5%. Big difference.
So what you're saying is very interesting, right? And it might affect how we traditionally look at things in medicine, because the purpose of myself as a GP and as a community doctor is preventative medicine, screening people, checking people, and you wouldn't really, a lot of times you wouldn't really be looking for it routinely in a young person, right, and a teenager. And from what I'm gathering from you is that we underdiagnose in teenagers who have diabetes.
Yeah.
So is it that we need to start screening kids?
Yes. So
Right.
and the ADA has that guideline. It's
Right.
been around for about
Right.
since 2016. It was the earliest
Right.
one I saw. And there's the special age group for adolescent.
Yeah.
So if you have 2 or more of the risk factors, family history,
Yeah.
either of East Indian descent,
Yeah.
African descent.
Yeah.
If you have acanthosis nigricans, that's the darkening behind the neck.
Yeah.
If you have, if your BMI is over 30, although that's not very accurate, we don't
Yeah.
like using BMI too much. We tend to go more with your waist to hip circumference.
Yeah.
So if
you're
you have,
round.
yes. So if your waist is more than 2 inches above the hip,
All right.
so two or more of those, you
right.
should screen them.
So very importantly, Doc, you're speaking directly to parents out there, right? And you're basically saying to the parents out there, get your kids checked.
Yes.
And especially if your kids have 2 or more of those symptoms that you described. And you could just go through it again, please.
So acanthosis nigricans.
Which is a darkening of the skin.
Yeah, so just look in the back of the neck for your child's skin, the back of the neck, you'll see the skin darkened. There's a nice dark ring around it. Parents often mistake it for dirt and spend time scrubbing, use peroxide, use all
Which will
sorts of
never
things.
go away.
Yes.
Yeah.
And they just irritate the skin instead.
Yeah.
If you know your child is obese,
Yeah. Family history.
family history, 95% of the population of Trinidad is either East Indian or African.
Correct.
So that's the majority.
So we need to screen the kids.
We basically need to screen
So
them.
what would you tell the parents to do? Take the kids into the GP?
Take kids to the
And
GP,
how
and
should
for
they
the
screen
GPs, we do not do a HbA1c for this age group.
Okay, good.
The tag for when you're testing them, you do a glucose tolerance test.
Right.
Not the fasting blood sugar, not the capillary test.
Yeah.
You do a glucose tolerance test.
All right. So is it that, I mean, for that category of patients basically highlights the entire population, as you pointed out, right, of teenagers?
That would, I would
More
say
or
about 75% of
More or
our
less.
population.
So is it that all the kids need, all these adolescent kids need to get the glucose tolerance test done?
Most of them would be, I would
Right.
say.
All right. So that's the issue with the teenagers that we see, and that's what has you perturbed in the clinic. How could we prevent this problem in teenagers?
So,
Because the future is the teenagers. We're talking around the topic, talking about the problem we have.
Yes.
Can we solve this problem?
yeah, so we
I mean, is
we
it real
can't
blunt?
solve it,
Is that real
but we
blunt?
could
Yeah, tell me.
we could make a big dent in it.
How could we make a better Trinidad and Tobago going forward in terms of diabetes?
So simple measures.
Yeah,
Diet.
yeah,
We need to cut out the sugars.
yeah,
We need to cut back the carbs.
yeah.
We need to increase fiber. The water intake in the tropical climate is not 2 liters, it's 2.5 liters.
Right,
The exercise.
right,
30 minutes per day.
right.
These kids in the adolescent clinic tell me, ask them, so what you all do in recess, lunchtime? Sit down and talk. I don't remember doing that when I was in school.
Which wasn't that long ago.
Recess, lunchtime,
Yeah,
30 years ago, but
yeah.
recess, lunchtime, you're running
Yeah, of
down,
course,
you
yeah.
hurry to eat, you want to go and play
Yeah,
football, cricket,
Yeah, yeah. Run around.
volleyball,
Yeah.
some sport you're in.
Yeah,
But these kids now don't.
yeah.
And we need to address this.
Right.
And they've done a lovely study in the US to get the Ministry of Education on board. Very simple. During the class, you tell the children, okay, let's walk around the class. Walk around class 3 times. Stand up, sit down. Stand up, sit down. Do that 10 times.
Yeah, yeah.
That's it.
Yeah.
They do that 3 times
Yeah.
in the class. The grades of the children
Yeah.
improved
Yeah.
significantly.
Yeah.
They were more attentive.
Yeah.
They saw their weight went down.
Yeah.
There was actually one study which was checking their sugars and blood pressure, and they saw improvement.
All right.
And these children were happier.
Well, that's a good point because we have to integrate that into the schooling system. So maybe we should have PE more than once a week and so on. What is it? So that's the exercise part of it, right? Is there? All right. So the food part of it is you're saying less carbohydrates, less sugars.
Right. So when I say carbohydrates, I should rephrase it.
Yeah. Go ahead.
So we need to have more carbohydrates, complex carbohydrates. So we want the oats. And oats is not instant oats. When we say oats, we're talking about rolled oats, steel cut oats. The instant oats is heavily processed.
Of course, yeah, stripping away of its fiber.
Right, and because of that, that's why it cooks fast.
Yeah, of course.
But what you want from the oats is the fiber. So you do that, you lose it. So I remember in Scotland, when I was there, the length of time all the carbohydrates taken to release from 2 slices of bread, white bread, takes 20 minutes.
Right.
Whole wheat bread takes 40 minutes.
Right.
Just add in 2 pieces of lettuce and tomatoes to it, and it went up to 90 minutes.
Right.
Just add in your greens, your salads to all your meals, and you see a big improvement.
All right, Doc. So we're going to take a little break now. When we come back from the break, we're going to push on a little bit beyond the adolescents, and we're going to talk a little bit about the adult diabetes. And then when we push on a little bit more and talk about the complications and the treatment of diabetes as well. All right, guys. So we're going to take a little break. I'm here with Dr. Navindra Persad. I am Dr. Roopnarine, and we're talking about diabetes. I would just like to encourage you to send in your questions and your comments. The doctor is here with us to help you out there. Whatever questions you have about diabetes, if you're suffering from the problem, it's a topic we haven't spoke about for a long while. Reach out to us, send us your questions, your comments, and Dr. Navindra Persad will certainly attend to it. All right, guys, we'll be back in one moment.
Connect with ACTN The Voice on Facebook or Instagram at ACTN The Voice.
ACTN The Voice, your family-friendly station.
ACTN The Voice launches a new and versatile culinary series called Stacy's Kitchen.
Hi everyone, welcome to Stacy's Kitchen. And on today's episode of Stacy's Kitchen, we will be cooking up a Thanksgiving feast. Our rolls are ready and looking yummy. Nothing like a good curry chicken and some basmati rice. So I'm gonna start putting my wings in to fry.
We will showcase how to make tasty international cuisine with our local products. We emphasize meals on a budget with our selected ingredients.
Restez à l'écoute, Stacy's Cuisine. Au revoir.
So you can put how much, depends on how big you want it. So our fish is ready. Oh my God, look at that. Oh my God, oh my God. Just like paratha, this is lovely.
Join us on ACTN on Monday evenings at 6:30 p.m. Don't miss Stacy's Kitchen, exclusively on ACTN The Voice.
All right, guys, welcome back. We're here with Dr. Navindra Persad. I just would like to remind you to send in your questions on the field of diabetes. All right, guys, make use of the opportunity of having the senior medical officer here with us tonight. Doc, just moving on a little bit from the adolescents. I understand really why you were really perturbed and you wanted to reach out about the adolescent care in terms of diabetes. But let's move on a little bit beyond the adolescents, right? in Trinidad, we sort of hear this term, like, I mean, a lot of patients would come in to me and they would say, I would say, I wait till you're diabetic. No, not diabetic, but a few years ago, the doctor said I was pre-diabetic. I basically tell them we've kind of moving on from thinking like that pre-diabetes is probably now shifted the goalpost into diabetes. What do you have to say about that, pre-diabetes, when people say they're pre-diabetic? Right. What does that mean?
So pre-diabetes is a term we use which basically says your sugar is elevated, but it's not that high that it should cause problem, but it puts you at a very high risk of developing diabetes in the next 5 years. And the problem in our population, when you tell people they're pre-diabetic, oh no, nothing wrong with me. The doctors say I just have a trace of diabetes. So as far as they're concerned, nothing is wrong. And then they go back to their regular lifestyle. Now the data, for years, and for many years, you'd be accustomed hearing, if you're pre-diabetic, it's a lifestyle and diet. That's all you recommend. However, very interestingly, if you give them medication, so metformin, for example, those who are given metformin, we have data showing that if those pre-diabetics who are put on metformin, which we're accustomed giving the women with polycystic ovaries, because of the increased risk of diabetes for them, and those who are pre-diabetic, and they were given metformin compared to the group who were not given metformin, they took on average 7 to 10 years longer to develop diabetes.
Right.
And people are realizing this, and now it is part of the recommendation that you should consider starting metformin on this age group, in this category.
Describe the category. Who is pre-diabetic?
So pre-diabetic is the ones who have an HbA1c between 5.9 to 6.5%. We say they're pre-diabetic. But again, I don't like that term. I tell my patients, no, you are diabetic. However, if you get yourself involved in an intense diet and exercise program, you are able to keep your sugar under control. However, this is the key point, you cannot change from this.
Can you cure diabetes? Can you reverse diabetes? We hear that people saying that on the internet. We're seeing people through diet have reversed diabetes. What do you say about that?
So you can be diabetic if you are grossly obese.
You can be diabetic
because of obesity.
Right, go on.
If we're talking about people with BMIs of 45 plus, we're basically talking about the people who have 350 plus pounds.
Right.
The majority of patients that we see with diabetes are not that weight.
No.
We very rarely come across those patients. So you have the diabetic, the diabetic patients who are only diabetic because they're obese.
Correct.
And that's a very, very small percentage of our diabetics.
Right.
The vast majority of our diabetics are diabetic mainly because of genetics. And yes, they're obese, so they got diabetes faster.
Right.
And if they don't address their obesity, they're going to have plaque buildup in their blood vessels, result in stroke, heart attacks.
All right. So before you go into that, which you have to, what I'm getting from you is that it's not a negativity that we're fighting a losing battle, but that you are saying that we manage this because we're trying to prevent you from becoming diabetic earlier.
Yes.
Why is it important to prevent somebody from becoming diabetic earlier? Why is that important? Why we can't just treat them as diabetic and save them and they're fine, and when they have a problem with diabetes and the sugar high, we give them best medication because diabetes is a chronic illness. Why is it so important that you keep emphasizing, since you started the program, that they're going to get this thing 5 years earlier, they're going to get it 7 years earlier? Why is that point important? Why we want to prevent people from expressing diabetes earlier?
Right. So we've known this for years. After a certain number of years of diabetes, invariably going to end up with complications. So all my patients, when I see them, first time I see them, I tell them, after we go through history, we give them what is their life expectancy. So if you're, regardless of your age, if you have a life expectancy of over 20 years, that means 20 years of living with diabetes. 20 years of diabetes, relatively well controlled, will result in eye damage, kidney damage, as well as severe plaque buildup in all your blood vessels.
And this is well-controlled diabetes?
Relatively well controlled. So,
okay.
if
You're painting a gloomy picture there, Doc.
so, we are very much behind globally. So, whereas you hear me talking about A1C, checking your sugar, what's your blood sugar readings, internationally, we're no longer talking about that. When you go to these conferences and the ADA meetings, American Diabetic Association meetings, the Internet IDF meeting, they're no longer talking about just your HbA1c and what is your sugars, fasting sugar, and after
Which is what the discussion is right now in Trinidad.
Yeah. Now,
So what is the discussion abroad now?
so now we have these continuous glucose monitors,
Yeah.
which they are the flash readers,
Yeah.
which you could check. You just like a scanner, you just pass it over. So it's basically a small device placed on your shoulder.
Yeah.
It's as big as a 50-cent piece,
Yeah.
and every 5 minutes you could check your sugar.
Yeah.
So those are the flash readers. Then
Yeah.
we have the true continuous glucose monitors,
Yeah.
which automatically check your sugar depending on the machine between 2 to 5 minutes.
Yeah.
So you no longer just get a blood sugar reading.
Yeah.
You get in a graph
Yeah.
showing you how your sugar is varying.
Yeah.
So internationally, we're no longer talking about what is your blood sugar.
Yeah.
We give you a target of what we want your sugar to be.
Yeah.
And we are now talking about time in range,
Yeah.
how much time you're within the target,
Yeah.
and glucose variability.
All right. All right. I think we're going a little bit off course there. In terms of the, I have to bring it back, Doc. We have to bring it back to the complications of diabetes. And even before that, I have to bring it back to, can we cure diabetes?
So
We didn't fully answer that
right.
question for the audience.
So 99.999% of patients who we see with diabetes, we cannot cure diabetes.
Is there a cure?
There is no cure yet because insulin resistance, it's not only insulin resistance because of extra fat tissue.
Yeah.
It's multifactorial.
Yeah.
So it's also that the insulin receptors may be defective in your body.
Yeah.
It could be that the insulin you produce is defective.
Yes.
It could be that the other hormones that interact,
I get your point.
as well as there's a counter hormone for insulin called glucagon.
Yeah.
And in some persons, everything is fine up to everything else, but your body just keeps producing excessive amounts of glucagon.
So you're basically saying that it's a little bit more multifactorial, a little bit more complicated, a little bit more goes on microscopically than what we explain in general to the public, that your sugar high and insulin being produced.
Yeah. So you can't
it's too complex a situation to cure immediately with one angle of treatment. Bring us back again to the to why we don't want people to have long periods with diabetes, with the complications of diabetes in other words.
So prolonged hyperglycemia.
Yeah.
And hyperglycemia really and truly is once your sugar crosses 124, your blood sugar, you have irritation to the cells. After 140, there's damage. After 160, there's cell death, starting with the nerves.
Right.
And we're talking about these sugars aren't that bad.
And I think you have a slide to show the.
So I have a slide there just to.
Josh?
It's just to highlight to people. It's too busy, and that's the point. When people think about diabetes, we just think about kidney failure, we think about stroke, we think about heart attack. No, it affects everything.
Yeah.
So we need to.
So basically, what you're showing people is that the complications of diabetes from head to toe.
Head to toe, everything.
And these are people who are relatively well controlled. You're still going to get a lot of these. You could still be vulnerable to a lot of these complications.
Vulnerable to these. So it's not just your high. It's not just your having high sugars for a week going to cause a problem.
Yeah.
We're talking about mildly high blood sugars.
Yeah.
Patients think, oh, my sugar is just between 140 to 180.
Yeah.
That's not too bad.
Yeah.
But
over a long period of time, it's problematic.
It's going to be. So your sugar went up to 180, but an hour later it went back down.
Right.
In 1 year, it's not going to be a problem. In 2 years, it's not going to be a problem. But 20 years later,
Yeah.
You've had those periods,
Yeah.
and it's going to build up, so that you will end up with problems.
All right. All right. So you're painting the picture, right? So but when every dark cloud, we're in a situation, somebody is diabetic.
Yes.
They want the best result.
Right. So let me go back to two nice examples I have.
Go ahead.
I had a 14-year-old boy.
Yeah.
When I first saw him, his sugars didn't drop under 400.
14-year-old boy.
14-year-old. He was thought to be type 1 diabetic.
Yeah.
Because young age.
Yes.
When we did our test for him, he's a type 2 diabetic.
Yeah.
I adjusted his medication. He engaged in an intense diet and exercise program.
Yeah.
He initially required insulin because his
Yeah.
sugars were so high.
Yeah.
In the space of 3 months, he was able to come off of insulin,
Yeah.
and he has lost his weight.
Yeah.
And this, I spoke to him about 4 months ago.
Yeah.
In the past year,
Yeah.
his sugar has not crossed 120.
Has not crossed 120.
Has not crossed
Real
120.
achievement there. Real achievement.
Intense diet and exercise. He's taking a very low dose of metformin. He's just taking half a tablet twice a day.
All right, so you're saying, all right, so you didn't cure diabetes,
No.
but you have him extremely well controlled with a maintenance of
I
this
wouldn't
diet.
say I am controlling him.
But he has it,
He has done what I wanted him to do,
which is diet and exercise.
in diet and exercise, and he has himself very well controlled.
All right, so I don't want to harp on him as an individual patient, but what's the prognosis for these type of patients later on? If they continue diet and exercise, they should be fine, right?
He's expected to live a normal life expectancy as a non-diabetic.
Okay.
So there's absolutely no reason for him to live. He's not expected to get accelerated. He's not at increased risk of heart problems, kidney problems,
Not.
stroke. He's not.
Right.
Nerve problems. He's expected to live a completely normal life.
And that's because he has excellent control.
He has excellent control.
All right. So now you are saying that in Trinidad we've been having problems getting people under control, right? Now you are saying that that let us use technology. All right, let us use technology, and that is where the discussion has arrived and reached in other countries towards bringing people under control. Let us use diet and exercise, and let us use the medications available, right? So you've highlighted a little bit of the technology. Why is the technology important to bring people under control? You told us that it gives you a reading every 3 minutes, but why is that important? Because most of my patients will take their sugar in the morning, and then they take it in the evening, and they know how to adjust the suit. Why is that outdated compared to what you were saying?
So now we realize that fluctuations in your blood sugar also causes long-term damage. There was a nice paper about 8 years ago where we had patients who had HbA1cs between 7 to 7.5% for 20 years. They all ended up with kidney failure, had a plaque buildup. We didn't know why. They shouldn't have. And then
Exactly.
we had another group
Because the
who had
HbA1c was well controlled.
we had another group who had A1Cs between 7.8 to 8.3%. 20 years down the line, they were fine.
Right, and the HbA1c was a little bit up.
Their
compared-
A1C was up,
Higher.
was higher. So when they look back at them,
Yeah.
the one who had the higher A1C but no problems,
Yeah.
they didn't have fluctuations in their sugar.
Okay.
Their sugar maintained steadily
Okay.
in that narrow range.
All right, so I just want to, so you are saying that the continuous monitoring will allow us to keep our sugar within the normal range.
So we don't even have to check to see what is the sugar. They send you get an alarm.
You get an alarm. And that would trigger the patient to go and take their medication or
Well, you'll know what to do. So if your sugar is dropping too fast,
yeah.
you'll get alert. So the patient isn't going to feel dizzy, lightheaded.
Okay.
Before that is happening, your sugar is dropping fast.
Right.
You'll get
So-
an alarm.
Right. So you
So
get the
no.
data before the fluctuations.
Before, yes.
So you know how to approach the
Yeah.
problem. And that, so what you are saying is that the fluctuations in sugar contributes to a lot of the problems you see in
Yes.
diabetics. And that would probably tie back, just moving here a little bit, because it really is a web that all joins in. But that point, that carries us back to your first statement about the diet and the carbohydrates and making sure you eat more fiber as well.
Yes.
Because that would result in less fluctuations in your sugar as well. So I could see how it interlinked there. So take us now to the medication. How could the medication we use help us control diabetes? diabetics avoid fluctuations and bring them to improved health. There are loads of medications on the market. We've flooded with them. What, how, and who?
Right. So there's too much medication on the market, too many choices.
Yeah.
And in Trinidad, we have a habit, tell the neighbor, oh no, I'm using this.
Yeah.
You should use this. It's working for me.
Yeah.
And neighbor will stop taking their medication and use what the other one give them.
Yeah.
But each person, we can't, yes, there's nice guidelines to follow.
Yes.
But each patient treatment has to be individualized.
Okay.
So we're not going
It's not a one-size-fits-all with diabetes?
No.
Okay.
So first line according to the ADA is still metformin.
Yeah.
However, if the person has early signs of kidney damage or heart failure, then we want to use a SGLT2 inhibitor. There are also the GLP agonists, which are injectables. I have not used it in Trinidad. I used it over in Scotland, and the amount of GI side effects the patients had there, I'm very apprehensive to use it here.
Okay.
Patients would tell me they're using it. No, it's not a problem. I only vomiting about 4 times for the day, and I have to use the washroom 16 times.
That's a problem.
They don't have a problem with that. They are happy with that. I don't know any Trinidadian who's willing to deal with that.
Doc, the metformin, right?
Yes.
It's a real miseducation in the community about metformin. Give us the right education about it.
So
let's put it out plain.
Metformin is still first line. Metformin has been, you know how drug companies have been. We know about all these scandals over the past.
Yeah.
Drug companies always try to improve a drug and try to make one better.
Yeah.
Because there's something called a patent which will expire.
Yeah.
And then their drug will be cheap.
Yeah.
So they don't want that. So they will always try to make something better.
Yeah.
They've tried for decades to make an improvement in metformin.
Yeah.
They made 3 other drugs after that.
Yeah.
All had to be thrown out.
All right. So metformin is the gold standard.
There are patients who've been on metformin for over 30 years and are doing well.
Right. So 2 things. The patients a lot of the time complain about nausea and vomiting, and after we discuss the metformin, we'll take a little break. Complain about like nausea, GI upsets. Is that a common complaint, and how do you respond to that?
So we give them a lower dose. So if they have, so I usually start them with 1 tablet twice a day. If they haven't side effects, tell them just be it for a couple of days. By the 3rd day, it should settle down.
Okay.
Almost all of them settle down. There are a few that don't, and I would usually just drop it to 250. If they still can't tolerate it, then I would try them with the slow release metformin, which not supposed to give that side effect.
Okay.
And if they still can't, well, then we just can't use it.
All right. So we're going to take another break, and when we come back, we'll talk a little bit about a little bit more about medications that people could use for this condition. All right, guys. So we're going to take our second break. Again, I'm formally inviting you to send in your questions on diabetes for Dr. Persad to answer. All right, guys. We'll be back in 1 moment.
ACTN The Voice welcomes you to join us for our newest agricultural television series, Harvest.
Welcome to Harvest. We're doing it double again, north and south. This morning we start here in Brazil Village on Bethany Estate with Michael and Jacinta Mill.
You can look forward to a personalized tour around scenic Trinidad and Tobago, showcasing different agricultural practices and teaching us self-sustenance.
So Wendy, you're about to show me your bromeliad house.
Yes.
Oh, this is lovely.
This is what our customers refer to as the Mecca for bromeliads.
Explore the many ways to make your harvest right for you.
So our chicken coop is more or less built at a height whereby it's easy for us to go and just remove the wood shavings into our barrow.
Now, you don't plant out your seedlings, you buy the seedlings, right?
Yes, we purchase our seedlings.
Here we are on a not quite monocrop site, but we have rows of tomatoes, rows of sweet peppers, and then you have the Milnes polyculturing.
Join us every Tuesday at 6:30 p.m. Harvest, a new dimension in agriculture.
Connect with ACTN The Voice on Facebook or Instagram at ACTN The Voice.
ACTN The Voice, your family-friendly station.
All right, guys, welcome back. We're here with Dr. Navindra Persad, and we're talking about diabetes. So, Doc, we're talking about the medications, right? You told us about metformin. Basically, sending a big shout out to people, don't be afraid of metformin. It still is the best. What other medications could our diabetics use?
So we also have the SGLT2 inhibitors.
Yeah.
Very good drug. And it's a very good drug. It protects the kidney, protects the heart.
Yeah.
But I also want to emphasize it does not give you a drastic improvement in A1C.
All right. Doc, a lot of the patients, sometimes they come in to see me as a GP, and they're like, Robin, do whatever you had to do, but I don't want to go on insulin. Right? And I mean, then sometimes you're thinking, well, you know, I mean, the cardiologist in the past would say, look, if you can bring people down under really tight control using insulin, insulin gives you a really tight control, that will reduce the risk of atherosclerotic disease, and thereby reduce the amount of patients who develop risk of stroke and cardiac attacks, heart attacks. What would you say to that? What do you say to those patients who do want to use insulin? Is insulin such a viable tool, or should we continue trying the different oral medications that they have out there?
So
when do you put a patient on insulin?
Right. So there are two circumstances you put a patient on insulin.
Yeah.
One, when you have type 2 diabetes, invariably your pancreas is going to stop being able to produce insulin.
Yeah.
And at that point, you need insulin. There's no getting away from that.
Right.
And there's a simple test we do called a C-peptide to assess if the body is producing insulin still.
Right.
The other one is the patients whose sugars are very high, and at that point they develop what we call glucose toxicity.
Yeah.
You can give them whatever tablet you want.
Yeah.
Their body will not respond to it because their body can't even recognize its own insulin. So you need exogenous insulin. So that is the insulin we're giving you to inject. So, and the point I want to drive home to that group of persons, this insulin is temporary. We're going to use it to get your sugar down, and then we're going to wean you off of it. Most of my patients who I put on insulin, I've successfully weaned off at least 70% of them.
Okay, wean them off the insulin.
Wean them off.
Is there any complications to insulin?
Yes.
Side effects?
Yes. So insulin, as a hormone, it's a steroid. It's an anabolic steroid. You know about anabolic steroids? They're used for doping. Very interestingly, just a side note, I actually had a boy in Scotland who was in the gym heavy, and he developed type 1 diabetes. As soon as he got put on insulin, start to bulk up, and we actually have a problem in that gym where
everybody started using insulin.
We have 5 persons doping on insulin.
Yeah. Because it's catabolic.
Anabolic. So you will build muscle, you will build size.
Right.
So giving somebody too much insulin,
they put on bulk.
You put on size. But if you're not exercising like those in the gym, your blood vessels going to get thick, stiff, hard, causing you to get high blood pressure, kidney failure. You're going to get more plaque buildup in the blood vessels. A high risk of stroke and heart attack. You're going to get fatter. You don't want any of these things.
No.
So you don't want people to be on insulin unless you need to.
All right. So that as well, Doc, it's a little bit of a shift from the older way of thinking about diabetes in Trinidad, where we rush people in. Well, not, I wouldn't say rush, poor choice of words, but we're keen to get people on insulin to get tighter control.
So you get the tighter control and then you wean them off.
All right. So you don't really want your patients on long-term insulin?
Once their pancreas could produce insulin, I don't want them on insulin.
Right.
I remember while I was in Scotland, we had a professor there. He said, very famous, one of the world-renowned professors in England, I could get anyone's sugar under control to insulin, so let me just use insulin for everybody. I'll put them on insulin, I'll get their sugar down, they'll get fatter, they'll put on weight, but the sugar will be good. And as they put on weight, I will increase the insulin dose, and the sugar will remain good.
Yeah.
They'll be dead in 5 years.
Yeah, because you're causing problems with the
You'd
animals.
be about 500 pounds.
Yeah.
But good
Doc,
sugar.
Doc, we need to take a little feedback from the audience. Josh, you have a question there that you wanted to put up? What about Janumet? How effective is it? That's the name of a medication for diabetes there.
So Janumet is a combination pill. It's a DPP-4 inhibitor with metformin. It seems to be pretty effective in Trinidad. I used to use it quite a lot in the past. However, with newer classes of drugs providing kidney protection and cardiac protection, I don't use it as much because at the end of the day, it's not just a blood sugar I'm looking to treat. I'm treating the patient in front of me. This patient is at risk of heart problems, kidney problems, already has, most likely, has one out of the two. I will look to target that first and then look to target. And then I would usually use that as a third line drug.
Third line drug.
Third or fourth.
I know what your first line is metformin.
First line is metformin unless they have heart failure, heart attack in the past, stable or early kidney damage.
What's the second line?
So then I would use a SGLT2 inhibitor, which would become first line if they have heart failure or kidney problems.
All right. So in terms of the Janumet, it's a viable medication.
Yes.
Doctors use it a lot.
Yes.
We've got good results on it as well.
Yes.
And it's a combination medication, and it obviously uses two of the classes of medication that is recommended internationally as well. Are we doing things? Are we being left behind in Trinidad in terms of diabetes care? You're a man that just came back from abroad. You've come back. You've been put in a seat of control, so to speak. Are we being left behind? Is the rest of the world moving forward and doing things that we are not doing?
Yeah.
And we need to know that.
We are. So basically, in terms of some of the drugs that we still have in Trinidad, when I spoke to my consultants about it, they were. This drug, they didn't know about it, and one of the professors was, oh yeah, we stopped that in England in the 90s.
All right, so you know what this points out? I mean, Doc, I'm really glad to have you on the program, but what you highlighting to me is that we need education. We need education not only for the public out there, we need education for our professionals. And I don't know, it's expensive sometimes to get education. We need to do it in a public way. We need our medical professionals, our nurses to be re-educated about what's happening in diabetes care. And we need the technology to be brought in and brought in cheaply to treat people, to monitor their diabetes. We have a few more questions that we're going to continue on, all right? So Josh, you could push forward the next question there for me, please. Hi, I'm a 71-year-old male. 3 months ago, I was diagnosed with type 2 diabetes with a HbA1c of 7.7. After 3 months of diet change and exercise, my HbA1c went down to 6.6 without medication. Diet and exercise really works. I lost 16 pounds. Well done at a 71-year-old male.
Yeah.
That is, he basically saying what you said about the kid and stuff. Diet and exercise really works.
It works very well. He reminds me of another.
71 years old, eh?
71 years old. He reminds me, I had another guy.
I don't know what he was like before, when he was exercising, I don't know.
I had another guy who was 66, came to see me. His sugars was, his A1C was 12%.
Yeah.
Had to put him on intense medication.
Yeah.
When he realized his sugars was getting good, he started to drop off medication. By the time I saw him, he came off all his medication. He had an A1C of 6% in 6 months.
That's real good. I mean, I think that's what we
phenomenal.
That's why some doctors probably say we put in remission. Not really cured, but we put in remission.
Remission. So as long as you could, so this is the thing. As long as you could continue that diet and exercise program, you don't need medication. You don't need to go on it.
I mean, I know we have a pile up of questions there, right? But it'd be real keen to know if that viewer could have told us what exercise he was doing. What exercise do you recommend to have the patient? I mean, is it aerobic, like cycling on a bike, running, swimming, or is it all like weights? I mean, weights build your bone. I mean, we had different doctors on a different types telling us. What do you recommend as the best type of exercise for diabetics?
Resistance training.
Weights.
So not necessarily lifting weights, but the bands,
Yeah.
the resistance bands they have.
Yeah.
Aerobic
Body weight.
Yeah, body weight. Aerobic activity does not help glycemic control long term. As soon as you finish the exercise, after about 20 minutes,
Yeah.
the muscles will shut back down
Yeah.
and your sugar will go back up. When you use resistance training, you break down the muscle, you use up all the glycogen stores from the muscle,
Yeah.
and then for 2 to 3 hours later, the muscle is still taking in sugars. The muscle has to rebuild.
Right. So resistance training.
Resistance. And I'm not saying to go to the gym and start lifting weights. Like you just said,
Yeah.
body weight.
Body weight. Or you could go and lift weights too.
Lift weights,
Body weight.
yoga.
Yeah.
Yoga uses resistance training.
Okay.
What I'm saying is, don't say I'm going to run on a treadmill, I'm going to cycle,
Right.
and think that's going to cut it.
All right, guys, so you get some really good information there, actually, Doc. Yeah, Josh, you could probably next question there. 72-year-old fasting blood sugar 130, is that bad? Fasting blood sugar. It's a real vague question, but
So he's 72 years old, it's isolated. This person could just be having, body sundown effect, where because of the stress hormones early in the morning, you might see the high fasting sugar. At 71 years old, that may not be a problem. You need to be, however, my recommendation for you is to get formal testing, to be tested either on HbA1c or glucose tolerance test.
all right. So glucose tolerance test is still widely used even for the adults?
No.
Okay.
So we only use the glucose tolerance test for patients with sickle cell,
Right.
anemia, sickle cell disease, if you have any sort of anemia, pregnant women, and children.
All right, so the HbA1c will settle for the rest.
Well, for this man, the
particular-
A1C will be fine.
All right, yeah, Josh, we're going to push on there. Next question. 74-year-old male experiencing head feeling warm with a slight dizziness with a warm feeling in the head and sleepy during the day. What does this mean? So it's a rough question there for you, Doc. It could be anything really, but
quite vague.
Yeah.
So again, we don't know if you have issues in terms of the blood pressure. We don't know if you're on medication, could be causing it. So is it?
Yeah. So viewer, you need to see a doctor. The symptoms could be, if you open the book, the symptoms could be from the top to the last page. You need to see a doctor, and you need a doctor to evaluate you. You'll do some blood tests, you check your pressure, check your sugar, you really check it from head to toe. You really need that. It's too wide a complaint for the doctor to narrow it down without information and data. All right, guys, so let's get the next question there, Josh. What is a healthy weight for a 10-year-old boy? Good question.
So let's ignore weight.
Okay.
When we're dealing with children, I don't like talking about weight, and especially boys who are going to start puberty.
Or girls as well?
Well,
girls are conscious about the weight?
No,
or you want to talk about weight?
The weight is, for boys, remember when they go into puberty, it's muscle mass.
Which makes them heavier.
Is heavy.
Right. Good
so
point.
let's not look at the let's not look at their weight. What we're looking at is their waist to hip circumference.
The belly, basically.
Basically.
Yeah.
That's what you need to focus on. So don't look at the weight, because we have guys who would be 120 pounds, but they have a waist of 36 inches. Then we have another guy who is 220 pounds.
Okay. So I get your point, reviewer. So we basically, what Doc is saying, that we're moving away a little bit away from just taking the rough weight, and we really need to look at the profile and the shape and where the fat is distributed on the person. Just give me a little feedback there. How much more questions we have? All right. Are you born with diabetes, Doc?
So that's a tricky one to say. So yes, you may be so in terms of type 2, you are genetically predisposed, but something has to trigger it off.
Right.
So that's where we talk about the environmental factors causing the trigger. Also, viruses could trigger it off as well.
All right. Doc, we have about 2 minutes left in the program, right? That's to round it off. That's the last question. We haven't left any untouched. Okay. You put forward some really good information, right, tonight, and I felt like you have a lot inside there that I'm trying to pull out. But what I got out here is, for us as medical practitioners, I think we need to be updated. I think there's a lot happening. You're saying that there's a lot happening outside Trinidad that needs to be happening inside Trinidad, and that's one for the authorities as well, and those involved in healthcare, not just the patients, because they're the ones that depend on us, right, to a large extent. The second thing I get from you is that, yes, like most of healthcare, the responsibility lies on the patient. And you didn't come here to sell a drug. You came and tell people that look, the key of it is diet and exercise still. And you're saying with your patient, with your doctor's help, that you could basically control this condition. You didn't come here to fool people either. You told them that, listen, there's no definite cure, but all your work is done to make sure that people don't have this condition earlier, and to delay the onset. And if you delay the onset, that they won't get these complications and have problems with the body and the health. So I think we take home messages that you wanted to present before you came here today. I think you've been able to achieve that. All right. And the second part is I just want to thank you for coming on the program. Thank you for taking the time to come out. I know you're a very busy man, and we appreciate it. All right. Do you have any final words you'd like to give to the audience out there in terms of diabetes care? Anything that you'd like to say to them?
So again, it's all about sticking to your diet, exercise, following the drug regime your doctor puts on you. If you have a problem with your medication, speak to your doctor.
Doc, you could go ahead and give the audience your contact details as well for your clinic and so on. Go ahead.
Yeah. So I'm based at Gulfview Medical Center privately, and you all can always email me. That's the best way to get me.
All right. So you'll leave your email address with Josh in the studio, and if anybody wants to contact you, you'll give them the email address, and you're based in Gulfview.
Yes.
Just that they can't remember the phone number for Gulfview at the moment. That's all right. All right, guys. So I'd just like to thank Dr. Navindra Persad again. It was an excellent discussion tonight. He gave a different slant to diabetes care, and I really appreciate it. And I'd just like to thank you at home for tuning in tonight, and we will see you again next week. Take care, everyone. God bless. Have a pleasant evening. All the best, everyone. Take care of yourself now. See you again next week. Thanks a lot.